Venkatesh.
So I'm going to today talk about surgical options for normal tension glaucoma. Do we have any role for minimally invasive glaucoma surgery? And I am Dr. Venkatesh from Aravind Eye Hospital, Pondicherry. As glaucoma surgeons, we are always looking at something which is very safe, at the same time less invasive, and also has got a very quick recovery because our patients need that. At this point of time, if you take any mix, who will benefit? Mainly patients who have open angle, whether they have mild to moderate damage or normal or low pressure, they should be open angle. And definitely there is a role for normal tension glaucoma, and also patients who have ocular hypertension and patients with early glaucoma but who need a cataract surgery. We can combine a MIGS. And any patients who have ocular surface disorders and not tolerating glaucoma medications. When you talk about mix, these are the options which are available. Subconjunctival drainage, we have the Zen implant. When we talk about enhancing the Schlemm's canal outflow, we have several options, starting from trabectome, iStent, Hydrus, gonioscopy-assisted transluminal trabeculotomy, Cahook's dual blade. And there's another way you can think of is suprachoroidal outflow. You have iStent Supra, and CyPass was available, but no more. And then finally, there are options which can also cause destruction to the ciliary body. So the viable options at this point of time, which we are also doing for some time here in Pondicherry, is one is suture GART, doing a gonioscopy-assisted transluminal trabeculotomy using a Phioprolin suture, which you see here. And the other one which we are doing is a modification of Cahook's dual blade. Cahook's dual blade is going to be available soon, but we are doing a small modification to that, which I will talk to you. So when we are talking about the suture GART, normally a GART is done using an eye-track microcatheter, which is very expensive. You need the light source and you need to have this disposable eye tracks for every case. But we have a less expensive way of doing it using the Phioprolin suture. And it can be cost effective. We have to prove that it is cost effective, but at least in our hands for the last couple of years, we have seen that the efficiency or the effectiveness is very good. What do you need for a suture GART? You need a low temperature cartridge, very important, to make a small snub in the suture. You need a nice gonioprism, a Swan-Jacob gonioprism to do intraoperative gonioscopy. You need Phioprolin suture, and then an MVR blade. Good viscoelastic, especially Healon GV, is very important. And also these two forceps, MST forceps and McPherson's forceps. This is all you need in addition to what you do for your regular speculum and things like that. So this is the low temperature cautery which you see, and the Phioprolin suture. So initially you use the cautery to make a small snub here so that the sharp end of the suture will not damage the angle structure. So that's how you do that. A small snub is done, and then you keep the suture, and then you make a couple of side ports. One is the main side port and the other is the main port. And if you're doing a phaco, you can do a regular phaco incision, or else you can make a side port like this. After that, you reform the chamber with viscoelastic, and you place the Phioprolin inside, and then position the patient. The positioning is very important. I'll talk to this a little bit later. And using an MVR blade, you make a small nick in the trabecular meshwork to open up the Schlemm's canal. So here you see blood in the Schlemm's canal, so there is a little bit of ooze. So you may have to clear that with viscoelastic and again visualize it. And then using the Phioprolin suture, you enter into the Schlemm's canal and you start catheterizing it. This is where that MST forceps is very important. You have to have a nice hold and grip, and then gently clock hour by clock hour, we should to push the suture. And when you reach 180 degree on the other side, you may have a little bit of resistance. Here, we are trying to do a direct gonioscopy to visualize where exactly the suture is. This is just to show, but it is not really needed unless you have a problem. And then you start continuing the catheterization until you get the suture on the other side of your entry. So normally you can even get 300 to 320 degrees. You catch the one end with your MSD forceps, and using a McPherson forceps from the side port, you pull the suture to do the 360-degree goniotomy. This is gonioscopy assisted transluminal trabeculotomy. The other option we have is the Cahuck dual blade. So basically it's a goniotomy blade, and it's a removal of trabecular meshwork happens. If you see in a GART, there is a residual trabecular meshwork, but in a trabectome, you also damage the surrounding tissues. Whereas in a KDB, there is complete removal of trabecular meshwork. As a result, there is less fibrosis and better outcome. Let's see how this happens. So KDB is designed like that. It's actually a dual blade. It's brilliantly designed blade. Again, you cannot use it for several patients. You may have to dispose it at the end of every case. There is a sharp tip, and then the sharp tip pierces through the trabecular meshwork into Schlemm's canal. Then the ramp helps you to lift, and then the dual blade does the business of excising the strip of trabecular meshwork. So depending on how many clock hours you want to do, 2 to 3 clock hours, you can do that. So this beautifully does, and then the trabecular meshwork is peeled off. So that is how a Cahuck dual blade works. So the sharp end enters through the trabecular meshwork into the Schlemm's canal, and then the ramp lifts it, followed by cutting of the trabecular meshwork by the dual blade. And then you do it on the from the other side so that both the ends meet, and then you can peel off the trabecular meshwork like this. So that is a simple way of doing it, which is called bang, where you actually bend a 26 gauge needle, and you can do the similar technique by bending just the simple needle. So again, gonioscopy is very important. And then through the sharp needle, you pierce the trabecular meshwork, you enter into the Schlemm's canal gently, and then you peel off the trabecular meshwork. You can see the peeled trabecular meshwork here. And then you can do from the other side for the required clock hours you want to meet. So this technique is called bang, a bent ab interno needle goniectomy. So this is also practically possible, and it is very simple. What is more important is intraoperative gonioscopy, positioning the patient. So here you have to turn the patient head away from you and tilt the microscope towards you. And you need high viscosity viscoelastic like Healon GV. And it's good to keep the patient head above the heart so that you tilt the table down, the leg end should be down and the head end should be out, so that you can prevent the blood reflex from the happening into the Schlemm's canal. And very important, you have to counsel the patients about the positioning even before, so that they may not be very uncomfortable. So this is where the head end is on top, and then you apply viscoelastic, you use the Swan-Jacob lens, and then you bring the microscope towards you, tilt the head away from you, and then you visualize the angle like this. So this is good to do even when you are doing a cataract surgery. Start visualizing the angle. Once you start seeing the angle, I'm sure many of these mixed procedures can become very easy to do. To conclude, I would say that mixed has a potential in management of normal tension glaucoma. There are a lot of evidences coming up for iStent and Hydrus in patients who have mild to moderate damage and also who don't have very high pressure, because definitely it reduces the dependency on glaucoma medication. So if you're combining a cataract, you can combine it with mix and do a cataract surgery. And also you preserve the conjunctiva for future manipulations or future surgery. And definitely at the end of the day, it improves the quality of life of our patients.